Hello and welcome to ABCDE Medicine's first video. We're going to be kickstarting with acute asthma, so let's jump straight in. As with all acute clinical presentations, we're going to be taking an A to E approach. And remember to break down every step of the ABCDE into assessment, interventions and investigations, and always check that the patient is stable before moving on to the next component of your A to E. Before we get on to the management of acute asthma, here are important differentials to exclude whenever a patient presents to the emergency department with shortness of breath. So I've broken it down into respiratory, cardiac and other causes. Important ones for respiratory are of course an asthma exacerbation, pneumonia, pneumothorax and anaphylaxis. For cardiac you'd want to exclude ACS, a PE, COPD and acute left ventricular failure. And finally, an anxiety attack can also mimic this presentation. So, we're going to be implementing the management plan of asthma within our A to E approach. A great mnemonic to remember for the management of acute asthma is "Oh shit me." You work through this mnemonic step by step depending on the severity and responsiveness of the asthma. So first line is oxygen, followed by salbutamol and hydrocortisone. After this you would consider ipratropium and potentially a theophylline, and then magnesium sulfate if it's severe or life-threatening asthma, and finally escalation. And although escalation is mentioned at the end, if at any point the patient seems unstable, you would want to be seeking immediate intervention from critical care. And of course, for severe or life-threatening asthma, you would want senior input very early on. Okay, so let's work through our A to E in more detail. First up, we have airway. So to check the airway is patent, a great way is to see if the patient can talk. If it's a yes, move on to breathing assessment. If not, check for any signs of airway compromise. For example, is the patient cyanosed? Open the patient's mouth and inspect. If there is sign of airway obstruction, seek immediate help from the anaesthetics team and perform basic airway maneuvers in the meantime. This is your head tilt and chin lift. If the airway still appears to be compromised, you can consider using an airway adjunct. The type of adjunct you use depends on the patient's consciousness level. If the patient is unconscious, they can tolerate a Gadel, which is an oropharyngeal airway. However, if the patient is partially conscious or awake, they will not tolerate this, so you would consider using a nasopharyngeal airway. Okay, so moving on to breathing. Quite a lot comes under breathing for asthma. First up, we want to know the patient's observations, so we're going to check their oxygen saturation, remembering that the target range is between 94 to 98%. Anything below 94, we would want to be administering 15 litres of oxygen via a non-rebreathe mask. We would then check the patient's respiratory rate, remembering that a rest rate greater than 25 indicates severe or life-threatening asthma. However, it's important to also note that if the rest rate starts falling and the patient is hypoxic, this indicates respiratory failure. So you would want to get critical care on board immediately. Under your breathing assessment, you would also want to examine the patient. So auscultate the lungs and note if there is reduced air entry, and also note the degree of wheezing. Moving on to the intervention for breathing, we're now going to start working through our "Oh shit me" mnemonic. First up for O, we have oxygen. Remember, we will only administer this if the patient's sats are below 94%. Moving on to the S, we're going to give salbutamol, which is a beta-2 agonist. This is first line for all asthma exacerbations. If it's mild to moderate asthma, we can give this via a pressurized multiple dose inhaler and spacer. However, if the asthma is severe or life-threatening, we want to give this via oxygen-driven nebulization. Moving on to the H of the mnemonic, which stands for hydrocortisone, so steroid therapy. The earlier this is given, the better the outcome, so this will be given in any acute asthma exacerbation. First line is actually 40 to 50 milligrams of prednisolone orally. However, if the oral route is unavailable, then we would give hydrocortisone IV. Now we've reached the I of our "Oh shit me" mnemonic. This stands for ipratropium bromide, which is a short-acting muscarinic antagonist. You would only consider this for acute, severe or life-threatening asthma, or those with poor initial response to the earlier stages of treatment. This is also given via a nebulizer. Okay, so now for breathing investigations. Okay, moving on to breathing investigations. We would want to order a peak expiratory flow rate to assess the severity and response to treatment. and we would also want to order a chest x-ray to rule out any of our differentials. However, these investigations should not delay management. Now we've reached circulation. We're going to start with our assessment as usual. So first we're going to check the patient's observations, their blood pressure and pulse to rule out any hemodynamic shock, their cap refill and also their temperature. Moving on to our interventions, firstly we want to get intravenous access. Because this is an acute presentation, we want to gain IV access via 2 large bore cannulas. We then want to take some bloods, so baseline bloods, which is your FBC, UNE and LFT. We'd also want to take a CRP and an ABG. And now back to our mnemonic again. We had reached T, which is our theophylline, so actually there is little evidence to support the use of IV immunophylline, and the side effects tend to be quite nasty and include arrhythmias. So this isn't routinely used in clinical practice anymore. Instead, if the patient has acute, severe or life-threatening asthma, skip the T and go straight to the M, which stands for magnesium sulfate. This would be given IV. And note that you would need review by senior staff before using magnesium sulfate. Second line to this would be IV salbutamol. Finally, we've reached the D and E of our A to E assessment. So for D, we want to check the patient's consciousness level using a quick and easy measure like the AVPU. You would also consider taking the patient's blood glucose. And then for E, we want to expose the patient and look for any other signs. In this case in particular, look for rash or angioedema because they could link to our differentials. And here's just a slide on classifying asthma severity. It's critical to know the signs and symptoms for severe and life-threatening asthma in particular because that does influence your management of the patient, as we said, working through your oh shit me mnemonic. Another great mnemonic to remember life-threatening asthma symptoms would be 3392 chest. That's a peak expiratory flow rate of less than 33% predicted, O2 sats below 92, signs of cyanosis, hypotension, exhaustion, silent chest and tachycardia. And just to conclude with the summary slide of the oh shit me mnemonic again. Thank you for listening. I hope this was beneficial. Please like, share and subscribe.